Good afternoon, my name is Sammy Butts. I am a full-time paramedic with International Falls Ambulance. I have been a member on this department for 7 years. I recently attended a conference in Salt Lake City and started quickly noticing a trend in topics as I was going through class. Sepsis was everywhere. I thought I knew everything there was to know about sepsis, but quickly realized I did not. One of the things that was a hot topic was the Sepsis Alert. I took a huge interest in it as my department did not have anything of the sort. During the classes, I learned that neither did a lot of the United States. This is something that the UK has been studying and researching for a few years, but we're really behind on the times. So decided to bring all of this newfound information I learned at the conference back to my hometown. We are a small town of about 6,000 people. We are a part-time ALS department and run about 1,200 calls a year. We have a nursing home, 2 assisted living facilities, 2 clinics, and 1 hospital. We take a lot of long-distance transfers. The closest specialized care hospital is about 119 miles away, but a majority of our transfers are to Duluth, which is 165 miles away, which is about 2.5 hours by ground. We see sepsis transfers all the time, but being able to call a sepsis alert in the field and getting them started on the IV fluids and antibiotics that much quicker will really start to decrease the mortality rate of these patients. So I started asking around my department, hey, do you know what sepsis is? Everyone always answered yes, but when I asked them to explain it to me, no one was really comfortable doing so. So part of my presentation is going to explain what sepsis is, and the other half is going to explain how we as EMS providers can recognize it and how we can start to fix it. We see a lot of posters floating around about strokes and heart attacks, but you never see anything about sepsis. The next video is going to show just how little people know about sepsis. These are some facts pertaining to EMS and sepsis. Going through the research online for this presentation, I was really dumbfounded by the mortality rate on sepsis. This is a crazy amount of patients, so why aren't we trained more to recognize this? Nearly 750,000 sepsis patients annually. About 500,000 are seen in the emergency department. About half of those in the emergency department arrive by EMS, and the mortality is as high at about 20 to 50% among sepsis patients. So do you know how to recognize sepsis? Let's start with this scenario. Mrs. Johnson, an 80-year-old female nursing home patient. History of a CVA, diabetes, dementia, and hypotension. Nursing home staff called EMS due to patient having altered mental status. She's usually alert to person in place, recently on an antibiotic for a UTI. Vital signs: blood pressure 88/40, heart rate 110, respirations 24, temp 101.4, O2 sat 94%. On your physical exam, she's non-communicative, moving all extremities, dry mucous membranes, lung sounds clear to auscultation, and she winces in pain on palpation of the abdomen, worse in the lower quadrants. Sepsis. What is it? The technical term, a life-threatening organ dysfunction caused by a dysregulated host response to infection. So no, really, what is it? Okay, now that we know a little bit more about sepsis, what can we do in the pre-hospital setting? Here's a look at a sepsis protocol implemented in the United States. Adult patient meets 2 or more of the following: altered mental status, GCS less than 13, respiration rate greater than 22, or systolic blood pressure less than 100, plus a suspected infectious source. If the patient meets the above criteria, then perform routine ALS as per standing procedures, obtain IV access, give 250 cc boluses of normal saline in rapid succession to a max of 2 liters. Notify the receiving hospital of the sepsis alert during report en route. Sounds pretty easy, huh? So once again, they must have hypotension less than 100, altered mental status, or tachypnea greater than 22. and any two of those with a suspected source of infection, some of them including pneumonia, UTI, cellulitis, intra-abdominal infection, cholecystic, appendicitis, diverticulitis, a C. diff infection, or others including meningitis, endocarditis, or bone and joint infections, and also remember to ask about risk factors for infection, such as HIV or diabetes. Some tips to remember. Remember to ask about the patient's baseline mental status, if they are altered, and obtain blood sugars. Place a large bore IV, such as an 18 gauge. Obtain 2 IV lines if possible. You may hang a 1-liter bag and infuse wide open. After each allocate of 250 cc's has infused, listen to lung sounds for signs of worsening edema. Remember, even patients with a history of CHF or renal failure can have severe infections and require IV fluids if they have severe sepsis. So now that we know what sepsis is and know how to recognize it in the field, let's get back to our case. The paramedic recognized the severity of Mrs. Johnson's illness and noted that her tachycardia and tachypnea and fever met the first criteria for the Sepsis Alert protocol. She also suspected a possible abdominal source of infection, such as C. diff colitis from the recent antibiotic use or a severe urinary tract infection. It was also noted that the patient was both hypotensive and displaying an altered mental status. She obtained 2 large bore IVs and began infusing a liter of normal saline wide open. Upon arrival at Rainy Lake Medical Center, the patient had received 500 cc normal saline en route and her blood pressure had improved to 110 systolic. She was found to have a severe UTI and continued to improve clinically with IV antibiotics and ICU care. She returned to her baseline mental status and was discharged back to the nursing home 4 days later in stable condition. So in conclusion, we have learned that sepsis is a common illness seen in the ED on a daily basis. Many of these very sick patients are transported by our agency. By following the Sepsis Alert protocol, we could possibly have a large impact on the survival of these patients.